And we are live. Good morning, Facebook, YouTube, Instagram. Back once again, hanging with Dr. Cooper. Good morning. Thank you all so much for your support and being here on this beautiful Sunday morning. Somebody's already popped in. I've already uploaded a bunch of stuff into the chat. So let me know you're out there, and I'll give you a little shout out as we move along. I am on today with my good friend and top doc, Dr. Kevin Woods. Good morning, Kevin.
Good morning. Thanks for having me.
Yeah, Kevin is a interventional gastroenterologist. We got a lot to talk about because, quite frankly, in the last several years, the field of gastroenterology has really just exploded with all of these new procedures and techniques to treat a number of things that you all are very aware of, in particular colon cancer, as well as obesity surgery. And we're going to talk to Kevin a little bit about that this morning. But first and foremost, we always do our little mighty intro, which is motivate, inform, educate, and transform. That's what we're all about on Hanging with Dr. Cooper. And we really want to help you get to where you want to be in your healthy life's journey. So, Kevin, give us a little background. Tell us where you're from, upbringing, and about your education and decisions to go into gastroenterology.
All right. Well, as many of your guests, and I've enjoyed watching and learning from all the docs that you've had. I'm from Atlanta and proudly raised in Southwest Atlanta, as I think you said, formerly known as, essentially worldwide known as the SWATs. I love that. And Dr. Pickens Patterson's post, but from Atlanta. Went to Frederick Douglass High School, and I started my journey there, and starting to think about what science would be in my life and how I apply it into medicine. I would say that was a great start, being taught by a lot of professors in physics and engineering and how we could apply engineering. I have to also say that in this great neighborhood and wonderful community of Atlanta, I definitely was exposed to medicine early. My father, Dr. Benjamin Woods, internal medicine, and of course all of his colleagues and friends had a great mentor as I started to think about the potential of medicine. Not like me and my colleagues, they may have known directly out of the gate that they were going to go on medicine, but for me, technology really bridged the gap of that question that was always being asked of me: are you going to be a doctor like your dad? And so trying to find my own way, I think technology is what really bridged that daily support and seeing what medicine looked like. Going out with my dad and my family, and I would see the impact of patients that will walk up at a Falcons game, or walk up while we were at church, or walk up and say thank you while we're in the grocery store, and I could see that community impact. And just like many doctors wanting to help people, but really obviously not knowing what my dad was doing when I was small, but seeing his impact, that definitely was a huge part of my development. And again, I didn't know I was going to go into medicine, but again, technology at Frederick Douglass High School, that was part of the CFET program, which was the Center for Engineering, Math, and Technology. And many of my classmates went directly to Georgia Tech, but I chose. As my dad said at the time, I have a twin brother. He said, "It's Morehouse or no house." So I didn't have a choice. Although I thought I was going to go to Tech, I didn't have a choice apparently, and went to Morehouse College here in Atlanta. And of course, was blessed to be taught by many of our great professors that many of us around the country who've had the opportunity to be a part of that brotherhood, for sure. Continue to solidify my path. Thomas Blocker, who's passed away, who was over the health professions, was integral into forming that discipline that was going to be required to go down this journey. From there, so from there went to.
So let me ask you. So that expectation was set. Did you feel any pressure from that expectation?
There's no doubt about it. I think, and it wasn't just from home, but Atlanta presented, for many people who've grown up here, presented so many examples of excellence, so many examples of accomplishment. I would say that it was expectation, but not so much pressure. The expectation was that you would do the best you could, and that you would apply yourself. And so I definitely continue to look backwards now as we can look at our careers and say, hey, we've accomplished things, but it's for sure a lot of other folks that you didn't do it alone, for sure. And that expectation in those times of study definitely kept pushing you through. So that was definitely important.
So let me send a few shout outs. They're checking in now. Y'all hanging with Dr. Cooper. I really appreciate it. First and foremost, my wife logged on #1 today. Thank you, Sandy. Our good friend Gloria Brooks is out there, and I always have to acknowledge my mother-in-law, Bessie Webb. Pam Brown is like a stalwart, always out there. Lady Phillips, how you doing? Marcella, I see you. Ken Kelly, how you doing, man? Thank you for logging on this morning and hanging with Dr. Cooper. We're talking to Dr. Kevin Woods, who is a top doc and interventional gastroenterologist, and he's got some real good information for us. Atlanta native. Doug went to Frederick Douglass High School, as did so many of the people I've met in Atlanta. Fantastic high school right here in the SWATs, and also Morehouse man. So that's what you all have heard so far. Tanya Redding Dennis, I see you. Lucretia, Carla Cooper. The Coopers are checking in this morning. Charles Pate, my church member, usher board member. Thank you so much from Cascade. So Kevin, from Morehouse, you went on to medical school. Tell me about that and your specialty and getting into gastroenterology.
So, like many of us trained around the country, went to Meharry Medical College, started at Meharry, and through my path, I actually thought I was going to be Dr. Cooper. I initially thought I was going to open chest and massage hearts, and cardiothoracic surgery I thought was going to be my calling until I had the opportunity to go and do a sub internship at Vanderbilt, just across the street. And at that time, I was applying to surgery, and I heard a lecture at the time that was about the treatment of GI bleeding. So many patients, suffer from this. And around 2003, 2004, some new technologies came out where you could actually swallow a small camera, and it would give you an insight with digital pictures of what was going on without having to open a patient up. And in Japan at the time, they were starting to create these new technologies that allowed us to take a scope with the camera all the way down into the small intestine, which was impossible to do prior. And the light bulb went off again, taking this love of technology and now, seeing where it can really benefit patients. And I decided really late, actually, I decided at that point I wanted to go into gastroenterology. So I switched all my applications.
That was a trip, I'm sure.
My chairman thought I was just nervous, and he told me to go home
rethink
it and survey 10 surgeons and ask what they would want to do if they didn't do surgery. And ultimately, I matched at Johns Hopkins Hospital in internal medicine. So in order to go into gastroenterology, you have to go through medicine. And so I went to Johns Hopkins Hospital in Baltimore, continued, this journey around gastroenterology, knowing technology was important, and met a great gastroenterologist by the name of Tony Kalu and many of the other fellows and residents that were working with him. And he was now starting to develop this novel area of what we call NOTES, NOTES, natural orifice transluminal endoscopic surgery. So here you go, matching this love for surgery. Now I've changed, and you can do all this through the mouth. And so training in his lab, it's 3 years of training. At this time, I applied. I met my wife at the time at Meharry, and we were engaged at this point. And I'm thinking I'm staying in Baltimore. She's from Baltimore. Well, I got an interview at Harvard, and thought that, this would be wonderful. I'll go and interview. But I really love Hopkins. I love the lab I'm a part of. And lo and behold, Massachusetts General Hospital, I matched there and went into their gastroenterology program in Boston, and had the opportunity to meet some really, really cool scientists, but also was trained by some really great guys up in Boston, and started to see where I could expand this endoscopic surgery to the next level, and trained in the Boston hospitals, and then came back to Emory as my first job. So coming back home, brought all those skills from the north, brought it back to the south, and started to develop programs to help patients that live here in the metro area.
Man, and I want people to understand here, we got some, if y'all don't understand what I'm doing, if you haven't noticed yet, what I'm doing is I got a pretty extensive network, and we're starting in Atlanta. So I want everybody in the Atlanta area to know who really are the top docs. And I gave it that name because I really think that, the community doesn't know. I get people all the time. I just noticed that Marcella Phillips in the chat said that she needed a good gastroenterologist. Well, you got one. It's Dr. Kevin Woods. If you scroll up in the chat, I've already put in his contact information. He's with the CEO and founder of Therapeutic GI Associates. He works out of Cancer Treatment Centers of America here in Atlanta, but that is his office is Therapeutic GI, and how you can get a hold of him. Also put his LinkedIn contact in the chat. But we got some heavy hitters here. Frederick Douglass High School, Morehouse College, Johns Hopkins, Harvard. What was the next stop, Kevin?
Well, the next stop after that was Emory here in Atlanta. So joined the faculty here in Emory. My dad, of course, I told you, he was very, very excited as I was the only sibling his only child that decided to go into medicine. And but I didn't do internal medicine, and so I came down and set up a gastroenterology practice through the faculty at Emory, and lo and behold, the first day I get there, I get a lot of screening colonoscopies sent by my dad, and he solidified that I would never leave Atlanta. So shout out to the startup, but was at Emory for approximately 3 years. Had a wonderful time developing my practice. I really still am an academic gastroenterologist. I think that as physicians, as you're doing now, we're teachers, right? It never ends. Technology changes, but an opportunity to join Cancer Treatment Centers of America as the chief of their interventional line. We've been around for 8 years now. Hopefully, if you've ever had a need to see an oncologist or a surgeon, that you would think very strongly about looking at all your options. And for me, it was a hard decision to leave academic practice, but many of us, like yourself, have seen the opportunity to serve more patients in other capacities. So starting my practice, starting up at Cancer Treatment Centers, had the opportunity to really build a world-class endoscopic program. We have wonderful PAs, we have wonderful surgeons and oncologists, along with a network of many surgeons just like yourself. I still send patients when necessary to my colleagues at Emory or Wellstar or Piedmont. But as we talk about gastroenterology, there's no doubt about it, we have a world-class capability to treat not only esophageal cancer or even reflux. We hope that nobody gets cancer. Our key is to really screen patients, make sure that they have what they need. And if unfortunately, as we all are living longer, cancer does unfortunately become part of our vocabularies as we see family members and friends and folks in our community affected by it. So we're there, and I'm very, very proud of what we've been able to build. So, that's where we are now. And that's
Kevin, let me ask you this. So let's tell us just tell the audience, where does good gastrointestinal health begin? That's your special. Where does it begin? How do we take care? We are now beginning to understand and really a lot of, I think a lot of, if you will, some of the things that I guess some of the outside influences on healthcare are beginning to have us understand the importance of gastrointestinal health and in importance of the gut on literally regulating just about everything in our body. And I don't think we really understood that until probably here in the last 5 to 7 years or so. So tell us how good gastrointestinal health begins.
Well, I like to start with my patients by the old adage, you are what you eat. And in many cases, we're in a pandemic right now, but we're also in an epidemic when we start to think about obesity, especially in communities of color. This is something that I suffer with. I think many folks in our family suffer with. And there are ways that we can control that because it does affect cardiovascular health. It does affect brain health with Alzheimer's. We start to see that maybe obesity is tracking with this. The microbiome, what we're made of, those microorganisms and bacteria that is in everything that we eat, how it actually develops the signature in your body of how to keep your gut healthy. We hear about probiotics. There are also foods that help stimulate that, antioxidants that helps our body go and repair itself. So again, you are what you eat. The number one killer in America, of course, is cardiovascular disease. So making sure that we're watching our cholesterol, making sure that we're having the opportunity to eat from the rainbow. So different colors of foods have different nutrient sources, and of course, that is the basis. Good nutrition is the basis of health and great health outcomes. So from a gastroenterology perspective, you have to start there with the diet. But other things that we can't control, which is our genetics. So for many of us, we can be living a great healthy lifestyle, but unfortunately, we inherited through one of our parents or both some genes that, when turned on by the environment and things we don't quite understand as physicians, then sets a cascade of unfortunately having issues like esophageal cancer or Barretts or colorectal cancer or pancreatic cancer, which really requires listening to our bodies. If you don't feel great one morning, don't pass that off. In many cases, although technology's gotten better, we still don't have the tests that can detect some of these issues early. So wellness is about forming a relationship with your doctors, being honest with yourself if you're not feeling great, and not ignoring symptoms when they first start.
Yeah, cool. So y'all are hanging with Dr. Cooper. I want you to remind you to do 4 things for me: like, subscribe, enable notifications, and share. Like, subscribe, enable notifications, and then share, so that we can continue to expand our reach in the community, not just Atlanta, but we're going worldwide here very shortly. I'm not going to spill the beans on that one, but more to come on that here in the next couple of weeks. You're hanging with Dr. Cooper. We're talking to Dr. Kevin Woods, and he's talking about gastrointestinal health. Kevin, I'll start with myself. Suffered with really bad reflux for a long period of time. And I guess about 10 years ago, found out that I had a short segment Barrett's. And so I have to go in and have, from time to time, endoscopy. Talk to us a little bit about what that is, what reflux is, what causes it, how we can prevent it, and some of the treatment options available for us down the road.
So reflux is a great topic for gastroenterology. Reflux has been around since the beginning of time. So I'll take you just through the thought process of how we used to treat this and where we're going. But Tums is a great chalky substance that we can find almost at every gas station that most people have taken at some point. Reflux itself is not a disease, and all of us, if we overeat or eat too late, we'll suffer from it. A little bit of burning in the chest coming, and sometimes it can get as bad as having you, unfortunately, vomit. But in this case, reflux does have, unfortunately, some effects that can change the lining of the esophagus, and then put our bodies at risk for changing into more, really, really worrisome symptoms like Barrett's. The stomach makes acid, and it protects itself by creating certain cells that secrete a mucus. Well, in the stomach, we expect acid, but we don't expect acid in the esophagus. So when those cells change in the esophagus to protect itself, those cells now are at risk. And as you know, and as I educate many patients, inflammation of any organ then sets off the cascade to cancer. So as long as it's inflaming substance like acid going into the esophagus, causing esophagitis, it then can now unfortunately influence those cells to turn into pre-malignant cells. And it's called intestinal metaplasia. I'd like to just throw that out there. Don't like to use a lot of jargon, but Norman Barrett was a surgeon, actually a cardiothoracic surgeon, that identified this uncommon, but now becoming more common condition due to obesity as well.
Yeah. So one of the things that it really it excites me. My mom died of pancreatic cancer, and there's one thing that excites me about all of medicine when I wake up every morning. It's just the advances. If that diagnosis of pancreatic cancer was made today, it's very likely she today versus what she had in 1982, she would have a 20-fold higher chance of surviving that than she did in 1982. And that just tells you how far we have come in advance. Today, there's over 20-something million people living with cancer. And when living is the operative word, not suffering from cancer or dying from cancer, living with cancer. And that's just amazing. So when I think about like reflux, when I trained, in the mid 90s for Barrett's with metaplasia, your option was surgery. Okay, pretty much that was it. But now you can take a scope and go in there and treat a pre-malignant condition with a scope and continue the surveillance. Not only that, you can treat one of the major causes of reflux, obesity, with the scope. So tell us what an interventional gastroenterologist, that's just amazing to me that you can fix something like that today without having to have surgery. Talk a little bit about the metaplasia or the reflux, the obesity, and how you can treat those things with all the techniques and tools you have in your toolbox.
Well, I'm so happy that for the first time publicly that a cardiothoracic surgeon has given so much love to a therapeutic
absolutely. Absolutely.
As we talk about this, you're right. I mean, this is one of the reasons why I really love gastroenterology. So first starting in the esophagus with that Barrett's, we can identify with microscopes now in real time. Once you're under with sedation, we can place a microscope right on the tissues and detect cancer in that setting. Then we go out and we remove that cancer. I'd like to talk about the GI tract like a 5-layer cake with the icing being here, my thumb at the top. We can remove tissue from here to here without causing any holes or any perforation. So therefore, we don't have to remove that esophagus, and you can continue to eat normally. Unfortunately, in some patients, if that tumor, that tissue is a little bit deeper, then we have to send them to you and your colleagues to remove and obviously protect them from having problems the rest of their lives. But again, using technologies like RFA, which is basically burning that tissue away without removing it, has been shown to be equivalent to surgery, as you know. And so people can live healthy lives. They just have to come back and see us about every 3 months in the first couple of years to make sure that tissue doesn't come back.
Yeah, that's just amazing. I'm so excited when Norm was my GI doc before he retired in 2019. And he had actually made that diagnosis about 10 years ago. And, I'm sort of watching this. I'm like, well, damn, I'm going to have my esophagus taken out at some point. Well, luckily it is not. It's still just, it's just Barrett's. It's not any kind of dysplasia or metaplasia at all. I had recent endoscopy with Dale Holly over at Piedmont and our recent surveillance endoscopy. And, I was sitting there thinking to myself, oh, man, if this comes back, I'm going to call Kevin because I'm not going to have any surgery. I'm going to have Kevin go in there and get this thing out of there, get this out without having to deal with any kind of any of my other colleagues who will put the big fillet on me from a surgery perspective. So it's really exciting. So Kevin, let me also now, one of the things that I think, the obesity thing, now you can treat literally, obesity surgery has really evolved. As you know, one of the pioneers, at least for that, in my opinion, in the city of Atlanta was Titus Duncan, general surgeon, who really has done a fantastic job with, raising the awareness of people who really have struggled with massive obesity for a number of years, and his ability to go in laparoscopically and do surgery, gastric bypass surgery, or gastric a reduction surgery, all types of procedures. But now gastroenterology has something to offer for people with obesity. Talk a little bit about that for us, please.
So you're right. Titus Duncan really brought revolutionary techniques in the 80s, early 80s and 90s that many of us have been able to see the impact of his work. Gastroenterology now, and I do have here on my desk just a small prop. Just a small balloon like this, which is actually basically a derivative of a breast implant.
I was going to say it looks like that. Yeah,
it actually looks like that, in about 300 cc's. We place this in the stomach, and it's not a surgery. It's not meant to be permanent, but for 6 months, on average, a patient can lose about 30 pounds. And of course, with all of us knowing 30 pounds is a lot of weight to lose. I think we heard Dr. Patterson talk about last week, the 5 pounds and how much that can put on pressure on the lower back. Or you can imagine any patient going for surgery, 30-pound weight loss makes you feel a ton better. So although this is not a cure like a Roux-en-Y gastric bypass that Dr. Duncan would do, or a bariatric surgeon, it does help those that maybe have a BMI of 30 to 40 and not morbidly obese, but really needs to help them kick off a better and healthy lifestyle. This is something now that's been over the last 15 years around the world, but now about 6 years ago, the FDA approved it, and over 250,000 procedures have been done safely with very, very low side effects.
Wow. So I'm getting ready to come over there and get this balloon put in my stomach because I need to lose about 30 or 40 pounds. But so you're telling me that you put in a balloon in the stomach and it makes you feel full. Leave it in there, and on average in 6 months there's a 30-pound weight loss
or more. If you're really good
wow.
about your diet and exercise, you can lose even more weight. And then we take it out at 6 months. Soon the FDA will approve it for a year, and then you have to take it out, so you can't keep it even though you're doing great. But we can then put a new one in, and then you can go for another 6 months. And
Wow.
again, a healthy lifestyle. But you can't overeat because unfortunately you unfortunately vomit. So it really helps us train our bodies how to eat, again, with a healthy lifestyle. And that lifestyle change hopefully will be something that you will continue and keep the weight off.
Yeah, I mean, you and I both know, and most healthcare professionals know that, and beginning to understand the psychology of health and wellness is really about our habits and how we really just literally gently or slowly sort of drift into these habits that are very unhealthy. But it's nice to know. If you all, just so you all know, I think that's the video that we put in the chat before we started. Isn't that right, Dr. Woods? The balloon. Yeah. So
and
we
I
put
saw
in the
a
chat
question here too. Mike Harvey.
Yeah. Mike. Yeah. Go ahead, Mike. Yeah. Go ahead. Answer the question. Go ahead.
Well, duodenum ablation. You must be reading our medical journals. This is a wonderful technology for those patients that, and again, becoming available for patients that have diabetes, where we think that we can change the way our bodies hormonally act by going in and burning the lining of the duodenum. And this is the place where we absorb about 85% of all of our nutrients. So by going in and going down into the stomach, into now the first portion of the small intestine, we burn that layer away. And then now we're seeing amazing changes where patients are now reversing their diabetes. There are other technologies that also include putting in like a small film that deploys from the stomach, a device that then layers like a plastic bag across the duodenum. And then it doesn't allow you to absorb, and you don't need surgery as well. So that was a great question.
And Mike asked again, can you do it? Yes, he can do it. Of course he can do it, Mike. That's why he's here. He's an interventional gastroenterologist. And trust me, this interventional gastroenterologist is on top of all of the newest and latest. Kevin is an academic at heart. He works at Therapeutic GI, which is his business, but centered out of cancer treatment centers of Atlanta. So absolutely, Mike, Dr. Woods' contact information, his office phone number is 770-400-9186. So we put that in the chat before we began as well. So thank you for that question. Mike is always very stimulating. Mike and I have been friends for a very long time. Mike's a former police officer. And and I've been chatting on social media for a number of years up in Cobb County. Great guy, always very, very thoughtful. And yes, Mike, you just found you a doctor. How about that? So did Marcella Phillips. Marcella, but no, go ahead and schedule me. You need to call him to get scheduled. He's not going to call you. We're not out here on the street scraping people up off the street to come in and do stuff to them. You call the number 770-400-9186, and Dr. Woods will get in his office. I guarantee you will get you in and get you taken care of. So, hey, let me give a couple shout outs. I got to say hello to my aunt, Alma Brown. Alma, I'm looking forward to seeing you this week. We're having a little Macintosh family reunion in Atlanta next weekend. So looking forward to seeing you all. Chad Lee, always supportive. Eric Boyd from the Lou. I'm sorry, KC, now in Texas. KC. Eric and I went to UMKC together. Jason Edwards, JE, what's up, man? How you doing, man? Thank you for checking in. And all your buddies are popping in, Kevin. So we appreciate that.
Morehouse.
So we're just going from the house. We're going from top to bottom. So we're talking to Dr. Kevin Woods, who is a internationally known, quite frankly, expert in interventional gastroenterology. Certainly, very, very well known around the United States as one of the top docs in this area. And so, for the audience and for people who are listening to this, what Kevin really does, quite frankly, is not only diagnose. So you say, well, you need to go in and get your endoscopy if you've got reflux, or you need to go in and get your surveillance colonoscopy if you have a history or you fit the criteria for surveillance. But not only that, and he was surprised to hear that I really love the fact that he could do something about it. I mean, I will tell you, I'm going to go see a patient here this morning as I am working who had an esophageal perforation. And twice, my colleagues in thoracic surgery and the gastroenterologist in the hospital that I'm working this weekend have combined their efforts, put in a stent, put in a chest tube, and essentially treating the patient without having to make a big, huge scar on the chest and go in and surgically repair it in the traditional sense. They did have to do some surgery, but not the type of surgery that required excision or putting sutures directly into the esophagus. This is amazing stuff that they're able to do. So now one of the things that you talked about earlier in the opening, Kevin, we talked about the esophagus and taking care of reflux and dealing with the end stage of reflux, which is Barrett's, and being able to excise and literally surgically remove that endoscopically. We talked about obesity. Mike sent us down the road of dealing with the issue of now a potential procedure to cure people of diabetes. So we got combined obesity, diabetes. Now we're moving on down to the small intestine. You mentioned the camera pill. Oftentimes, some of the bleeding issues that we run into in healthcare and some of the issues that affect patients in the small intestine, which is between the stomach and the colon. And it's, God knows, 21, 25 feet on average in most people, and you can't get to it. But now you can put a pill down there. But not only you can put the pill down there, once you identify where it is, the pill is giving you feedback, telling you how far it's gone, and you can actually go in there and do something about it now with your endoscopic techniques. Tell us about that.
So again, a groundbreaking technology called deep enteroscopy. And so this is taking a scope, as you just stated, with the help of a small balloon that allows us to just track our way, almost like a slinky, all the way down the small intestine. This is an outpatient procedure. Patient is put to sleep just as they would a colonoscopy or upper endoscopy. And you're right, it allows us to identify what we saw in that small video camera. The video camera doesn't quite have GPS in it yet, so we can estimate due to the time that it took to get to the colon. We can estimate how far it's potentially traveled, and that is game changer for patients with bleeding disorders, patients that unfortunately are on Coumadin or Plavix or other blood thinning medications that are required for heart surgery or having a abnormal rhythm. So it allows us to treat them, take them off those medications, treat them, and hopefully stop them from having any blood transfusions.
Yeah, man. I mean, I just, I think about that and I look at and just say, man, this is just truly amazing because, one of the conditions that I treat is aortic stenosis. And, there's a lot of those patients will have angiodysplasia in the intestinal tract for whatever unknown reason that is. And they're very difficult sometimes decision-making because replacing a heart valve, sometimes they'll need blood thinners. And then they got this situation where they're bleeding in their GI tract. So now we have the help of our gastroenterologist. In the past, again, all we could do was really, in some cases, do blind surgery, if it was that severe. And now we can actually, pinpoint, localize through this deep enteroscopy and really provide the patient relief from their heart condition, but also relief from one of the side effects or one of the associated problems with that, which is angiodysplasia in the small intestine. It's very hard to diagnose and also to treat. But now we're slowly but surely we're climbing up on that. So Kevin, I was coming through the airport the other day, coming back from Kansas City, and the big billboard up there and on the wall, and let's just get to the big one now, from Terrence Howard, who the actor Terrence Howard is talking about his mom, who had died at the age of 56, if I'm not mistaken, was on the billboard there in the airport at Hartsfield, 56 years old with colon cancer. And of course, this was a PSA, public service announcement, to get people to understand their risk of colon cancer, get the colonoscopy done, and to get treated sooner rather than later. And of course, Chadwick Boseman sort of put the spotlight on this here in the last couple of years with his death at a very young age from colon cancer. So talk to us a little bit about colon cancer. That's a biggie that everybody's concerned about, and everybody wants to know what they can do to prevent it, and also some of the things that can be done now for surveillance and for treatment.
So I think colorectal cancer is such a huge issue that we don't talk enough about. So thanks for bringing this up. We just, I guess now it's June, but in March is Colorectal Cancer Awareness Month. And
Right.
as you've already stated, if folks don't know, I mean, lung cancer is the #1 cancer in the U.S. incident-wise. And for women, second is breast, and then for men, is prostate. And then for both men and women, colorectal cancer is the #3 most common cancer in the United States. Public service announcement for all that kept saying, I'm gonna wait till I'm 50. Just about 2 months ago, we've changed that now 45 is the new 50. So 45 is now the new screening age for all Americans to get screened for colorectal cancer. You may ask, why did they drop that age? Is because we're starting to see younger patients now present at much higher stages, meaning sometimes past an early stage that would require chemotherapy or cancer. So now the government is agreeing to pay for colonoscopy at a much younger age so we can actually catch these polyps before they can actually hurt us. Colorectal cancer starts with a small polyp, which essentially is your genes are turned on, unfortunately, by sometimes smoking, sometimes obesity, sometimes just having bad genes. But it takes about 10 years for a polyp to turn into a malignant tumor. And the way that we can the best way to actually identify these early and treat them is with a colonoscopy with gastroenterologists. We have wonderful gastroenterologists all through Atlanta and the state and also the nation. So really, we want to make sure that patients know that this is a test that's no longer using twilight anesthesia, as some of our viewers may have had that in the past. We now use propofol, which is a nice anesthetic that goes into the arm and keeps you, essentially you won't know that you had a procedure. And you wake up having your colon reviewed, obviously after drinking a nice solution to move all of that stool out of the way. This is so important in the Black community that we have to start to break down the myths and also break down some of the frustration, especially in our men that don't want to talk about colonoscopy, don't want to talk about health. I really admonish and challenge everyone to, as you approach 45, and I'm close to it, so maybe I'll do mine live on your show, Coop. But
okay, we can do that.
we have to do all we can to get the word out that you need to see your doctor to be screened. I'm just going to take 2 seconds to say that never underestimate things that can change. And so if you ever see blood in your stool, that is one of the things that we notice that younger patients tend to blow off, saying, oh, I may have had a hard stool, or I may have eaten something that caused bleeding. Just know that is a warning sign. And if caught early, usually that's a lucky find for a patient to find bleeding, so that we can go on quickly and try to identify the source.
Good. Kevin, I got a couple questions in the chat I want to address. We're going to go back to something we talked about a little bit. What is the criteria for what is the BMI cutoff for? This is from Christiana, one of my nurses at Wellstar formerly, that asked, what is the criteria for the candidate for the balloon therapy for obesity? What are the criteria generally for that?
So the FDA approves it for a BMI of 30 to 40, but just like many medications and also devices, as long as your doctor, if you have a BMI that's lower than 30 and say you have high blood pressure or you have diabetes, and you can still benefit from this technology, then it's just a consenting process to say you do know that this is now being used off-label, but again, it's safe, it's effective. And so patients that don't fit into that strict 30 or 40 BMI can, in fact, have the procedure. Things that make you not a candidate is if you've ever had a gastric surgery. So if you've already had a gastric bypass, of course, you don't have a stomach to put this in. Or if you have any active gastritis or abdominal pain or ulcer, of course, we want to make sure that the stomach is healthy before we actually attempt that procedure. But again, please reach out to me. I'd be happy to take those questions and help you on your journey.
Yeah, so Kevin's number is Dr. Kevin Woods, interventional gastroenterologist, and we're discussing gastrointestinal diseases in general. His number is 770-400-9186, 770-400-9186. That's therapeutic gastroenterologist. Carolyn West in the chat. Her daughter has gastroparesis and Crohn's and she is scheduled to go for a I don't know what that is. Something procedure, how successful. What is that called?
G-POEM, P-O-E-M,
Okay.
poem, but oral endoscopic myotomy. So this is very interesting procedure. Gastroparesis, for those that are watching, is just when the stomach is slowed. It does not empty. A normal meal should clear your stomach by 4 hours. A liquid meal should clear your stomach by 2 hours. And unfortunately, some patients have a meal that can sit there all day and not be digested. So I'm sorry to hear about your daughter suffering from that. G-POEM is done by just a few of us actually in the country. Here in Atlanta, it's done at Emory, and it was also done down at Cancer Treatment Centers of America. We do offer it for select patients, but G-POEM procedures are becoming, again, a non-surgical way to treat a disease of the stomach. So before, you would have a PEG tube or a tube from the outside to go in to help with feeding, or in some cases, you would end up removing the stomach. So this is a great technology and technique that is emerging over the last 5 years to really help patients with gastroparesis.
Got it. So that's great information. Again, another potential solution to a problem that is very, very difficult, has been very, very difficult to treat in the past. I want to come back to the colon, and I'm not going to let you all off the hook. Kevin and I both are proceduralists, and we love to do our procedures, but a lot of this stuff is preventable. Okay. And a lot of it's not necessarily, we're here because sometimes you all and us too, we don't do the things that we should be doing. Kevin, talk to us a little bit. I struggle to get that 25 to 35 or 40 grams of fiber in my diet every day. So I have to supplement. I take Benefiber, sometimes Metamucil, and that's a struggle for a lot of people. Really, literally, you almost have to eat a bag of apples, I guess, to try to get that in. So, but as you know, fiber intake has been shown. It's very, very important for not only GI health, but also for cardiovascular health and other problems. So talk to us about how we can best try to get in that fiber cutoff of 25 to 30 grams a day, or whatever it is these days.
Yeah, and I'll back up and say, not only just fiber, but I try not to use the word diet. I'll use a diet in the traditional sense of what we eat, but diets in the sense of changing what you eat for a short period of time never works. So for those that are Weight Watchers, what they're teaching you to do is count calories, which is a great thing. It's education about reading labels. When it comes to things like fiber or red meat or alcohol, there are a lot of things that we need to be really thinking about. Fiber, for example, fruits and vegetables. Every time you increase your intake of fruits and vegetables, you really win in so many ways. One, there's no cholesterol in fruit and vegetables, so of course you have great heart health. Their body cannot break down fruits and vegetables from a perspective of the pulp, right? That pulp is the fiber, and that cleanses the colon. So we're not exactly sure what the interactions are between food and hormones and your genes. We haven't figured that out to prevent cancer, but we do know that patients, based upon large numbers of studies, that have active walking, daily exercise, along with water intake, because the colon is the place where we extract most of the water that our GI tract either produces or that we drink. Fiber is going to be key to that. So supplementation is great, and you should do it. Of course, some patients suffer from constipation, and some of that is due to just not moving enough. But diet, exercise, and trying to eat as much fruits and vegetables in the morning. For breakfast, obviously, a bowl of fruit would be great. Cheerios from a brand perspective, or a brand muffin, for example, can give you a ton of brand fiber that you can put in. We just have to watch the sugar, because many of these brand muffins are almost like desserts now, right? You can eat a brand muffin and feel like you have a sugar rush. So we really want to watch.
No doubt. Yeah.
Well, but for sure, brand fiber and many of our cereals and oatmeal can help us get that fiber that we need, that we may not get with fruits and vegetables.
That's fantastic. I want to get to Vanessa Kemp. That's her alias. I'm not going to give her a real name, but Vanessa Kemp, one of my former nurses as well. What are your thoughts on Remicade for treating Crohn's disease?
Crohn's disease is an inflammatory condition that is in the category of inflammatory bowel disease. And we don't know what actually causes this cascade. This is not one of those diseases where we know exactly what causes it, but we do know how to stop the inflammation. So we talked about that earlier this morning, how inflammation then moves to cancer. Remicade was one of the first drugs developed to actually stop that inflammation by targeting it with infusion therapy. So Remicade has been proven is one of the first drugs, meaning that now we have many other drugs that have been developed that have the same benefits of Remicade, but are somewhat a little bit easier to use in the sense that you can not have to go to the doctor and have infusion. You can actually take injections at home. Humira, for example, is one of those medications. But Remicade and the class of drugs it represents is an excellent treatment for patients that have moderate to severe Crohn's disease, for sure.
Got it. I want to get back to this colon cancer thing. So, Kevin, so the surveillance colonoscopy, very important, 10-year sort of latent period, and that's why surveillance colonoscopy is so important. You have a polyp, and I put the scenario out on my social media yesterday, and I've seen this on a number of occasions where you have literally, you meaning gastroenterologist, not necessarily personally you, but I know you've done it. Gone in for surveillance colonoscopy and literally diagnosed cancer right there on the spot and treated it with your techniques. Tell us about that. Tell us the size of the polyp. Tell us how that looks and what the follow-up should be for somebody who comes in routine and, got this big old polyp there. And now you don't have to send them to the general surgeon, which is what we would have done 15, 20 years ago, but you don't have to do that anymore. You can take care of it right there on the spot.
So exactly building on the theme that we talked about in the upper tract with esophagus, you're right. Colonoscopy, we find a polyp or a mass. We can remove many of them at the time of that colonoscopy. It's called endoscopic mucosal resection, or EMR, or endoscopic submucosal, meaning we go under the tumor, we carve it out, and then we remove it, the ESD, or endoscopic submucosal dissection. In short, and in layman's terms, we basically lift that polyp up off the wall and then we cut it out. And I can tell you that personally, I've removed a polyp, let's just say a polyp that's a centimeter or 10 millimeters in size. It's a high-risk polyp. We can remove polyps that are almost blocking, say, the colon up to 8 centimeters in some cases.
Wow.
And one key part to talk about is not every polyp is cancerous, so it's important to remove them and send it to our pathologist to guarantee this. But the follow-up would all depend on if there are any high-risk features, if there's any dysplasia or changes towards cancer, or unfortunately, in some cases, if there's cancer there. And then our pathologists tell us if we got it all. For some polyps that are larger in size, although many of these techniques are excellent, we still do require surgery to help protect patients long term. So although these technologies are available, in some cases, if we're not able to remove that polyp completely, or if it has any features that are suggestive of a higher risk tumor, then that patient still may even have to have that section of their colon removed to help prevent any long-term complications. All of us have a 6% risk if we're average risk. I think it's important we talk about symptoms, but if you have anybody in your family, and again, to talk to your family members about if they've had a colonoscopy, one, but if they had, was a polyp found? If anybody connected to you in the first degree, that means parents, siblings, and then children connected to you, ever had a polyp, then that puts you in a high risk category. And therefore, that means that you should have your colonoscopy every 5 years and not every 10. And unfortunately, you would need to start 10 years before the screening age. And as again, 45 is the new 50. So if anybody's had a polyp in your family and you're sub 45, then you just go 10 years from 45. So that could mean 35, you'll start screening to remove these hopefully small polyps so that you're not affected.
So we've had a couple of questions. Thank you for that, Kevin. So, it really is, it's just truly remarkable that now that potentially the colonoscopy can be therapeutic, diagnostic as well as therapeutic, but also an adjunct in the case of those that are much more invasive or have features of a more aggressive tumor, if in fact tumor is diagnosed. Been a couple questions in the chat that we want to get to before we end here about diverticular disease, and then Faith Jones, my homegirl, and put in the chat here. First colonoscopy, they had pockets. I think what they're describing perhaps is diverticulosis, which is a very common condition of the colon. Kevin, you want to comment on that?
Yeah, so it's a theme here. I'm gonna say we're not exactly sure what causes diverticular disease or outpouchings or pockets, but what we do know is over time it is a normal finding that defined in the colon, as Dr. Coop just stated. This can be complicated by diverticulitis, which is actually when you start to get pain and inflammation, and many folks know that have had this. It can sometimes require surgery in the first episode. But we think it's due to a motility issue where the colon is just not moving as well, or it just causes an outpouching because that muscle in the colon has become weaker. Again, if it causes significant symptoms that require you to seek emergency attention, like bleeding or abdominal pain, that's when we start to think about not just watching, but to take that section of the colon out. And but this is something that many of us suffer from. One of the hot topics I can tell you that I'm probably sure if they haven't asked it already is how can you prevent it? It used to be the old adage is to stay away from popcorn, seeds, and nuts. But I can tell you for those that like popcorn, seeds, and nuts that patients did better when they ate those things. So although that was, even when I was training, that was something that we told patients, but a really, really large study was done to show that that's actually not the case. So again, good health in the sense of great fiber to try to sweep the colon by staying regular and diet and exercise. We hope that can prevent folks from having to lose parts of the colon.
Got it. Thank you all for hanging with Dr. Cooper. This has been Hanging with Dr. Cooper, another episode. We've been talking to interventional gastroenterologist Dr. Kevin Woods. I need you all to do something for me. That is go and on all my social media, like, subscribe, enable notifications, and share with your networks. Kevin, give us a few last words, anything we missed, or you want to get out there to the audience that you think is very important that we perhaps did not discuss.
Well, I think you've highlighted. I think we need to continue these conversations around our families and to really start to think about our health journeys. One thing is that we will not live forever, but medical technology and taking care of ourselves really can push our lives into a much more prosperous place. Health is your wealth. So I think if you're not here, as you say, you can't help others. So put yourself first, start to meditate, think about the things that you need to do to change in your life to have good GI health, to have good cardiovascular health, and decrease stress. I think that is always a good way to end. Go out, get moving, and if you have any questions or any way we can help, please reach out. We'll be happy to see you.
Yeah, I think you made a very good point there, and I really like to always reemphasize this. There is, in the grand scheme of things, nothing that we do in health is going to prevent you ultimately from dying. You are going to die. What we really need to be focused on, however, is living our best lives and living it to the fullest right now. And quite frankly, staying out of doctors' offices,
Sure.
and enjoying all of the best that life has to offer us. So with that, we'll end. I really appreciate you all hanging with Dr. Cooper. Remember, today is the best day of your life. Yesterday is gone. Tomorrow is not promised. Live life, live it well, live it now. And I'll see you next Saturday, 9 a.m. We're doing it this month. This is Juneteenth, Men's Health Month. A lot of things going on this month. And we're going to have our Back by Popular Demand, my buddy and top doc Dave Montgomery coming back to talk about heart disease once again. So once again, thank you all so much. Reach out to Dr. Woods, 770-400-9186 is his number, as well as his practice as Therapeutic GI Associates. Kevin, thank you so much once again.
Thank you.
Have a fantastic Saturday, everybody, or Sunday. And I hope you all are getting back to church live now. We are really all just desperate to see each other and to be close to each other, at least 6 feet apart once again. Y'all take care. Have a fantastic Sunday. Goodbye.